to nerve roots? Steve? What's the other thing that happens when we get a bulge? It can affect the conduction of the nerve root. It can also affect its movement. So we have the signs of dural mobility or root mobility, which is the... No. First, before you'd even think of the slump test. You'd think of straight leg raising. You'd think of opposite side straight leg raising. And you think of the prone knee bend to go to a higher level. Although some work that came from Cyprus, funnily enough, you don't often hear of Cyprus as being very much, except perhaps I should tell you, talking about Bosnia and all these places, that the Canadian troops, we've just withdrawn our troops because we've got sick of Cyprus. Okay, we've been there for 30 years. The Turkish Cypriots are north and the Greek Cypriots are south, and we've walked up and down this line, and there's been a room there all set up, and in 30 years the people have never met, and it's cost us $500 million, and it's just the same as it was 30 years ago. That's our great effort in Cyprus. Just kept the people apart until now. So we're going to draw out what's going to happen. I don't know. Interesting thing, isn't it? But from Cyprus came this stuff, that the prone knee bend isn't just a test of L3. It could be a test of 4-5 disc problems, because, of course, that's part of the femoral plexus, L2, 3, 4. The unfortunate thing was it didn't really describe how they did it, and it didn't sort of describe whether they tried to eliminate, when you went back into this position, an anterior rotation of the ilium, which is going to produce a hyperlordosis in the lumbar spine. It doesn't describe those really important things to us, and we are interested in the perfection of how tests go on, because a lot of the time you make a neural test an articular test, and we've got ways of kind of cutting that out, which very often, some of the tests that are done, to be quite frank, are done quite crudely. Without precision, which doesn't seem to suit the way that we like to think about doing these things. For example, let me just take Sandy for a second, being as she's laying down. Lay on your back for a second. Let's just take an example of doing a straight leg raising, which we know we need to keep it into its neutral position. We need to keep it in the mid position of adduction and abduction, because going into adduction tightens the root, going into abduction slackens the root, keeping it in medial rotation tightens the root, going into lateral rotation slackens the root. So to standardize the test, we've got to have everything like this. And we know that to start with, as I come up here to this point here, we've got a little bit of tension increasing on the whole of the sciatic nerve. And it's not until I get above about 30 that I start to move the nerve above the sacral alar. And then we're moving the root now with that sinusoid, that curved part of it, out of the intervertebral foramen. But of course, by the time I get up to here, it's also becoming an articular test for the sacroiliac joint. And if I get further, I can sort of see that I'm going into more of a flexion of the lumbar spine. So what starts off as a neural test of neural movement now becomes an articular test. But as I come into this position here, I could back off a little bit into that position, go back to the sacroiliac joint, increase the backward rotation on the sacroiliac joint, which isn't doing anything for the sciatic nerve. And if that reproduced the pain, I'd be thinking more of the articular elements of this test. Or I could take it up to here, produce the pain. I could take a wedge and put it underneath the sacroiliac joint so that that can't go into posterior rotation. And if that sort of removed the pain or increased the pain, it would tend to make me think of sciatic nerve movement and not in terms of the sacroiliac joint. So we can alter some of these tests by just doing slight alterations of movement. And I think on this kind of quadrant test, this is important. And I want you to kind of think about how can you modify tests. I can't think of every way, and in fact, you know, I mess about with some of these things, and I'm not sure all the time that it's particularly valid. For example, just to take a slightly different track, let's say the Patrick's test, Faber's test here, coming into this position like this. And we find that in Sandy's case, and I'll just make this up because she's got a fair amount of movement, let's say I get down to here and that's stiff and painful. We know that this is a test which is affecting the hip joint and the sacroiliac joint. So, if I get it to this position, easily take the leg up like that and take the pain off, then I can go onto the sacroiliac joint and produce a backward rotation on the ilium like this, which is producing or reducing the movement on the sacroiliac joint, but it's increasing the movement at the hip joint. So if pain comes back now, I would tend to think of it being a hip joint originating pain. Whereas I could come down to the position here, which is causing this sort of outflare at the sacroiliac joint. I could back off into this particular, and I could then put some stress on the ilium to see if I could reproduce or change the pain, the hip not being in its painful position. So there are a lot of ways that we can modify tests so that we can tend to force the movement. When we know it's over 3 or 4 joints, we can force the movement to one joint and remove the stresses from another joint. And we'll spend a little bit of time today on looking at some of these things. And you can, when you get back to your patients, you can kind of see if any of them have got any validity. I think that this is somewhere we should be moving. Okay, so that's a very important thing. Thanks, Andy. So, if we look at these essential conclusions, I think from the whole of the scanning examination, this is what we really need to pick up. Is there a spinal problem? And then what are its characteristics? Now, if in fact we have a spinal problem, and none of these are positive, okay, then we can go down perhaps to this little group and call those a spinal dysfunction. And then we've got to decide to ourselves, okay, what kinds of tests do we need to do now to identify the level? Because we've got only know that movements of the lumbar spine cause problems of a particular characteristic, but that we've got no neuropathy, we've got, thank goodness, no myelopathy. The straight leg raising isn't being particularly helpful, or the prone knee bend. So we now need to look at signs of dysfunction. Now, for the purposes of this course, and I'm certain that this is not necessarily the way that Mackenzie uses this, but I'm going to sort of say that if we have a spinal articular problem with neuropathy present, I'm going to call that a derangement. And essentially the synonym in this particular thing for derangement will be discogenic, if you like. I guess that's why you brought all this new immaculate stuff so it can be seen. Although this will look quite messy, I'm sure. Okay, this we'll call discogenic, and we'll decide what we do with that in a minute. What I'd like you to address now within your groups are, what are the signs of dysfunction? Okay? And did Cyriax in the basic scanning examination address this at all well? If he didn't, what we've got to do is to add some further procedures to the scanning examination once we've got to this level. How did he tell the level, and what do we need to tell about the level? So that's the next thing. What are the signs of dysfunction? We've talked a little bit in the break, and I talked with Anne last night on the telephone about, our communication back to doctors. What do we say? Do we tell them all these sort of things? I doubt it. We've got instability in this direction and that in that direction and all this. I would doubt that. I don't think that we need to put ourselves out on a limb so much and irritate them because they can't do it and they think we're criticizing them. All right? But I think there are terminologies that we can use that are not so threatening. And I think that's what we should use in our reports. And we can talk a little bit about this. And Anne's got a very good article that she's going to discuss in terms of how do we communicate. Because after all, we are going to be the kind of consultants within physical therapy and manual therapy, aren't we? The more experience we get. Hopefully we'll be the ones that will be consulted. So we've got to have some means of communicating. So what are the signs of dysfunction? Let's just spend a couple of minutes in your group and come up with the signs of dysfunction, because this is going to give us another pathway that will indicate further testing and differences in treatment. That's very important.
You're not saying that dysfunction and derangement are the same?
No,
okay.
no. Lois. I got you, Lois. I got you. Do you know these strange things where people who, like Shirley MacLaine, may feel there's cosmic forces at bay? We have a Kent on the same table for Superman and a Lois on the same table. And a Steve, the Joker, Steve Allen, and the Joker was part of this. So this is just things that happen. Like on a plane, you know, 50%, there's a 50% chance that two people have a birthday on the same day. This is just the probabilities of just random happenings, no cosmic stuff going on. That's kind of interesting. So this table, Steve and Lois, I'm going to have to work on your table. That's put me off. I haven't quite got your names yet. I have to work on that. Okay, so I'm saying derangement we'll use just for convenience to mean a discogenic problem, and a discogenic problem with nerve root implications. What's the route that we'll go? We're going to learn and do. I mean, you know the techniques, but we will sort of refine the techniques that we can do for this. Now, we're saying that those that don't have, I do this and I've got pain, and I do this and I've got pain, and this is okay and that's okay, but these other movements were painful to me. And we looked at this neuropathy and myelopathy, nothing. So we're calling these a dysfunction in the segment. And what we need to do now is to sort of talk about what are the features of dysfunction? Did Cyriax address them? And if he didn't, what are we going to do to address, to find them, and then, of course, to treat them? So, just work in your group. 5 minutes. That'll be quite long enough for that. Important as it is. Could have hypermobility. And if we've got hypermobility, what's the next thing that we ask ourselves? No. Well, you could ask yourself that. But in terms of just these broad things. Yes, the stability of it. Is it just a joint that's a bit loose, or does it have very marked translation movements in certain directions? What is your definition of instability?
Accessory movement.
Exceeds the physiological.
Okay, that's probably the physiological events that lead to it. Farfan's very interesting. He's got a very interesting definition, which is a clinical definition. He says that his idea of instability is if you can take a perfectly functional, or a person has a perfectly functional back, and suddenly with very little stress it makes it a very dysfunctional back. Because in other words, it cannot absorb even reasonable stresses. So he has this clinical definition of having a back that can go from being perfectly reasonable to being very dysfunctional with hardly any stress. And then we look at it and we say, what is this? And as you say, it's when we look at any movement of the spine, we've got angular movements and we've got translation. And with instability, the translation movements start to now exceed the reasonable controlled translation that goes with a particular angular movement, and it can be in certain directions. And I think as far as the lumbar spine is concerned, the best way of thinking about it is to take an example, something that we've all seen, which is perhaps, let's say, a torn anterior cruciate, where the knee's perfectly stable in most directions, but one direction we've got marked translation. And when they do various things, the translation is not controlled and it shoots across the envelope of motion, and the patient just can't manage it with their neuromuscular system because it's outside their level of experience. And so we can look at it clinically in stability of just converting a back that's, having a bit of trouble to a back that's suddenly very dysfunctional for very little stress. That's Farfan's description of what instability is. And then we can look at the reasons, and then we can look at perhaps other ways of doing it. So, great. What's the next way that we can look at this? This is like the other side of the coin. Another way of looking, depending on which school of thought you come from. This would be like the manual therapy school of thought.
At dysfunction or at altered movement? What are you talking about?
No, we're talking about dysfunction. One of the signs of dysfunction is altered movement. Are there any other signs of dysfunction?
Abnormal end field.
Yes, the answer to that was abnormal end field. Can you go a little bit further with that?
Well, I was thinking the way you said manual therapy, if you are looking at overpressuring that.
Okay, this would come back a little bit to this, I think. Once we've taken it to its extreme. How about the muscle energy approach? What does that look for?
Altered flexibility?
No. Although that's part of it too. Altered position. So that when I go through hyperflexion or hyperextension, we end up with a sagittal plane movement where we have produced a unassociated lateral movement. So that as I go forward into flexion, I could say that this bone is not moving symmetrically and it twists. So that when I go down and I'm looking at the transverse processes, I would say that that bone is rotated and side flexed to the left on full flexion. In other words, an ERSL lesion. So altered position. But of course, that's also a way of looking at motion, isn't it? Because we always ask them to go through the motion and we look at what the terminal situation is. So altered position. Now, these are the same coin. It's just one side or the other. If you were a chiropractor, they go much more on altered position than we do. What's the other evidence that we might have of dysfunction?
Neuromuscular, or like, I don't know how to use the general term, neurophysiologic changes,
In?
muscle tissue.
Yes. And?
Dermatomal, the sympathetic nervous
Yes.
system, reflexes.
Good. Kathy is on the ball. TTA, tissue textural abnormalities. That's an osteopathic term. And all of these are present in dysfunction. We tend to focus, depending on which day of the week it is. If this is our muscle energy day of looking at problems, then we'd be looking at altered position. If it's our days for being manual therapists purely, we could look at this. This is present and interesting, and I think it needs to be addressed. The problem is that it's not accurate enough to a segment. It shows that there is dysfunction in the area. Chan Gun, who is a neurophysiologist, did a lot of very good work at the Workers' Compensation Board in Vancouver, in Canada, and he produced an article which was called Early and Subtle Changes of Spinal Dysfunction. Early and subtle changes of spinal dysfunction. And largely, these were to do with skin changes and super and subcutaneous tissue changes. How did these show up? They showed up as when you press the tissues, you get that sort of orange peel effect. Marked increase in the follicle size and so on. If you took a matchstick and you take it in a normal tissue and you press it in, it makes a mark and it quickly eradicates itself. But in the area where there is dysfunction, it's like a pitting edema, which Chan Gun called trophoedematous changes. And that pit stays there for quite a long time. Very often, and this goes back, you see, this is where we have this, all of these various schools come together. And this is what Core was talking about and Denslow when they were talking about the facilitated segment. And we get perhaps increased sweating. If we run our hands over this area, there may be changes in the erector pylorem of the hair follicles here. So it gives that goose pimple effect. And of course, in the terms of a facilitated segment, there is hypertonicity of the arterioles of the skin so that the skin is cold. So these are all changes of tissue texture abnormalities. And at some time in the next 2 or 3 days, we'll kind of look at this. Anne can just stay there, and I will do a bad thing to her through her clothing. Actually, you could just pull your shirt up here for a second. Okay? Some of the evidence of some of this stuff is you've a Kibler's test, for example, where you roll the skin like this, and you look for its flexibility, and you come to an area where the skin is hypertense like she's here. I'll leave that area alone. And I know that in that area there's an area of dysfunction. So we can look at this from the skin, I can look at it from the subcutaneous tissue point of view, and I can also look at it in terms of flexibility. And I think that some of this skin mobility and myofascial mobility is something that we should address. Not so much in terms of, the myofascial school of thought, because they've kind of put all sorts of trauma and everything else into this, which seems to be going beyond what we're, competent to deal with some of the time. But certainly in terms of the flexibility of the skin and the flexibility of the tissues, here like this, we should be looking at this because it's part of segmental dysfunction. So all of this we need to look at. But I think there are emphases we make, and then this is other stuff that perhaps we come up to a little bit later in our examination when we're trying to sort of complete a treatment. We have to make our commitment to a certain structure and then treat it and then sort of see what the response is like. Now then, what is the advantage of this? The advantage of this is this, that both of these two things are dysfunctional states, and this and instability will be treated in a totally different way than hypomobility. But do we do instability tests on everybody that we see? No, it would be a waste of time. We need to sort of have something that indicates whether we should be thinking about doing instability testing. Now then, from your knowledge of Cyriax, did Cyriax address this with any great degree of precision? No, he didn't. What he did as far as getting a segment that is affected is concerned, and I'm not sure that he addressed it, and I always sort of defer to Anne here because she was much closer to him and she was lucky in that regard than I have been. But what he did as far as his local stuff to the back, there were two things he did. One was he palpated the muscles of the back to see if there was any major deformities in the back, such as a rotoscoliosis, that he could feel that there were bony changes and so on. And the next thing that he did was he did a postero-anterior pressure at every level. Now, I'm not sure that he did that to tell that this particular joint was affected. He did it for that reason, but the other reason that he did it for was that he used quite a lot of direct downward thrusts in his manipulation. And if you had a spine that was like this, that would resist that, that would not be a technique where he would use his second technique. His first technique were two rotary techniques. His second technique was this posterior push. And he was using that to say this technique is not appropriate for this patient. But in Maitland's sense, we could use those posterior pressures to try and pick up something that we could look at. Because if we've got a movement pattern like this, all right, and we've got, say, pain as we go to the left, forward flexion halfway, pain on the left-hand side, we don't know in this lumbar spine which of these segments is affected, particularly if it's just local pain. So we can do our postero-anterior pressures at each level. And we can, from this point, we can focus a little bit, let's say, on L3, 4. And then when we start doing our more specific tests, we can really concentrate a bit on this and above and below, so that we've got some guidelines as to where to draw our comparisons. So we need to focus, constantly keep focusing on an area of dysfunction. And I think that's really quite important. So, Cyriax didn't do this very well, so we need to put in. How are we going to investigate that? From the things that you've done in your practice, how do you know the difference between hyper and hypo?
Biomechanical evaluation?
Yes, or specifically, what techniques? Yes, yes. We would use intervertebral joint motion. Passive intervertebral joint motion. Now then, what would indicate to you if instability is a possibility? Have you any evidence at this moment? We've done the scan and we've done intervertebral joint motion. From the scan, what have we got? You've got Farfan's thing. He was somebody that wasn't doing very much and has created quite a problem in the back from what seemed to be a very trivial stress. So we kind of think, yeah, and how many times have you had this? Well, it seems to be getting more frequent, and each time it takes longer. So from the history, there's perhaps something. Is there anything in terms of the movements that you would see that might suggest to you there's some instability here?
Trick movements.
Good. Okay, so we go down like this and we come up like this, or I go down and sometimes it goes this way and sometimes it goes that way. Things like this, or that when we go down like this, we perhaps see that there is a big gap as they go down. There are all kinds of little sort of indications which we just take into our heads and file it as we continue going through this. So we've got the history, the frequency, the lack of any great stress, then the trick movements that come in, so that's all very helpful. In our architectural design, we might feel as we run down the spinous processes that there's perhaps a very slack feeling, posterior ligamentous structure between two levels. That might be a little bit indicative. Not totally, but it makes us think. Then we get into this. And what do we find when we get into this? Intervertebral joint motion. That would say, look, go a little bit further with this.
A segment that has a lot more motion.
A lot more motion to start with. And also, what else does it have? What's... Yes. Something else. Might do. But supposing you palpate out the ligament, what do you feel usually with a hypermobile segment? It's very, very sensitive. So if you are palpating along the